Yes.
Yeah.
Okay, so you can't walk and talk.
No.
All right.
I won't.
All right. Good morning. Let's get started with grand rounds. This morning's speaker is one of our chief residents, Johanna Baer. Johanna joined us for residency after going to medical school in Germany at Justus Liebig University, and will be leaving in June to go pursue a transplant fellowship. And today she's going to talk about hemostasis and blood clotting for surgeons. Thank you, Johanna.
Thank you. Good morning. I'm going to talk this morning about modern concepts in transfusion and coagulopathy in the bleeding patient. All of us here have taken care of a bleeding patient or a patient in hemorrhagic shock. A lot of times this has happened on the trauma service, but also like patients on the general surgery, vascular surgery, or transplant surgery service. Shock is defined as inability of the blood to shock is defined as inability of the body to maintain adequate and organ perfusion. Hypovolemic shock is inadequate tissue perfusion caused by decreased intravascular volume and most often is due to blood loss after severe injury. In trauma, we got taught that we should always assume that hemorrhagic shock is the cause of hypotension in all trauma patients. It is the second cause of death for injuries and leading cause of preventable death. And it is a strong predictor of mortality and a major risk factor for the development of multi-system organ failure. This is just a brief overview of the different classes of hemorrhagic shock that we're all familiar with. Class 1 with minimal blood loss, less than 15% of the body volume with not really any physiologic changes. Then with Class 2 with 15 to 30% of blood loss. Early changes are seen with decrease in pulse pressure and tachycardia. Then in Class 3 where 30 to 40% of blood loss occurs, we see major changes in heart rate, blood pressure, and pulse pressure, and then significant shock. It's Class 4 where more than 40% of blood volume is lost. Massive blood loss, there are a couple of different definitions from massive blood loss, but basically means there's a lot of blood is lost over a short period of time, or significant ongoing blood loss over a prolonged time. Patients with massive blood loss are at higher risk of developing acidosis, hypothermia from blood loss, injury burden, and associated need for multicavitary surgery. This acidosis then can further exacerbate coagulopathy, which results in the vicious triad. I'm going to talk about that a little bit more later. But before that, I'm going to just briefly review the physiology of hemostasis and coagulation. Hemostasis, there are 4 major physiological events occurring, which is the vasoconstriction, platelet aggregation, coagulation phase, and fibrinolysis. All these occur in order but are interrelated to each other. Initial process is vasoconstriction, which is mediated by vasoconstrictors like thromboxane, endothelin, serotonin, or bradykinin. Then in the second phase, a platelet plug is formed to aid in the cessation of bleeding. Von Willebrand factor binds to glycoprotein 194 on the platelet membrane, and other platelets get recruited to the area. This is known as primary hemostasis and is still reversible. Then in the second wave of platelet aggregation, more mediators get released, and fibrinogen is a cofactor which results in a compaction of the platelet block, and this is no longer reversible. The third phase is a coagulation phase where the initiation of the clotting cascade begins, and a firm platelet/fibrin clot gets formed. And then last phase is a fibrinolysis, where the fibrin clot breaks down and allows restoration of blood flow during the healing process, and fibrin is degraded by plasmin derived from plasminogen. The coagulation cascade, we remember that all from medical school or for studying for the app site. There are 2 possible pathways which then converge into a single common pathway. The intrinsic pathway it starts with activation of factor 12 and then activates factor 11, 9, and 8. and it's called intrinsic because all factors are intrinsic to the circulating plasma. In the extrinsic pathway, tissue factor is released. The surface of the endothelium binds circulating factor 7. Both pathways then converge at factor 10. Factor 10 gets activated to factor 10A. Prothrombin gets converted to thrombin and fibrinogen to fibrin. Clot formation occurs, and after fibrin monomers are cross-linked to polymers together with factor 8. Coagulopathy, a lot of times we associate that with talking about the vicious triad, which these different hypothermia, acidosis, and coagulopathy are all things that kind of play together and worsen each other. And we talk about a lot of trauma in patients and that associated with bad outcomes. Coagulopathy results from mainly independent interacting mechanisms thought to be a result of the combination effect of acidosis, hypothermia, hemodilution, and loss of coagulation factors with continued bleeding and consumption. Additionally, in the literature recently, been talked a lot about acute trauma coagulopathy, which is a new coagulopathy that occurs early in the resuscitation phase. This schematic just shows sort of the interplay between trauma and shock and acute trauma coagulopathy, along with hypothermia, acidosis, leading to coagulopathy, which then in turn leads to more hemorrhage, which then worsens the shock, the hypothermia, the acidemia, and ends up in the vicious cycle. 25% of patients admitted after trauma develop coagulopathy, and it is an independent predictor of the need for massive transfusion and death. And there is an increased likelihood of protracted ICU stay, multi-system organ failure, especially renal failure and acute lung injury. I'm going to talk a little bit more in detail about the different factors that contribute to the coagulopathy. Hypothermia is caused by convection radiation from exposure, which occurs at the scene or in the resuscitation bay. Evaporation if the patient has wet clothes, reduced heat production, exposure of peritoneal and pleural surfaces during surgery, and fluid resuscitation. The effect on hypothermia acts primarily on platelet activation, but also slows the metabolic rate of coagulation factor enzymes. Coagulation factor activity reduces 10 to 15% for each degree drop in temperature. And the decrease in core body temperature increases mortality in hemorrhagic patients. Acidosis is caused by tissue injury, hypoxia, hypofusion, and subsequent production of lactic acidosis. It affects coagulopathy mainly by inhibiting the activities of enzyme complex on the lipid surfaces. Activity of factor complexes depend on interaction with negatively charged phospholipids on the surface of activated platelets affected by increasing concentration of hydrogen ions. Profound inhibitory effects on thrombin generation rate increase in the setting of hypothermia. Inhibits also platelet activation and accelerates fibrinogen breakdown. Hemodilution can be either caused by direct loss of coagulation factors through hemorrhage or through dilutional coagulopathy, which develops when blood losses are replaced with fluids that do not contain clotting factors. Studies have shown that in 40% of trauma patients can develop coagulopathy already after 2 liters of crystalloids administration, which can rise to more than 70% after 4 liters. And the volume of fluid administered is proportional to the degree of coagulopathy. Traditionally, the thought was that coagulopathy is something that occurs late in the resuscitation, but recently has been recognized that a lot of patients that already arrive in the emergency room are coagulopathic. So in the literature, the term now most often used is also acute traumatic coagulopathy, which is a distinct early coagulopathy which occurs prior to significant dilution with 30 minutes of injury. It's thought to be related to direct tissue trauma, hypoperfusion, and inflammation resulting in hypofibrinolysis and endothelial activation. It can affect up to 24 to 56% of trauma patients and is associated with an increased risk of mortality. The pathophysiology is not completely understood yet. There are 2 theories that get postulated. In the first theory, tissue hypofusion causes activation of protein C, which then leads to systemic anticoagulation hyperfibrinolysis. In the second theory, tissue factor activation of extrinsic pathways with resultant consumption of coagulation proteases and development of DIC with a significant fibrinolytic component. ATC is worsened by acidosis and hypothermia. Recognition and admission of ATC is crucial in that it can predict subsequent transfusion requirements and the decision to proceed with damage control or resuscitation. It's also an independent predictor of adverse outcomes with prolonged ICU and hospital stay and a fourfold increase in mortality. Traditionally, a PT and PTT is used to guide resuscitation. There is a new trend now to use sort of point-of-care tests like the thromboelastogram, and is more sensitive in measurement of coagulation disorders. It can also be used to monitor and suggest transfusion based on individual patient needs and promoting optimal product delivery and minimizing the risk associated with unnecessary transfusions. There is concern that current TEG assays have insufficient sensitivity to direct small changes in fibrinolytic activity required for optimal product delivery in a hemorrhagic patient. Just for a brief review, this is a TEG tracing, the different values on here. Just to explain this real quick, the first value is the R value. The reaction time is the time to onset of clot formation. Elongation represents a deficiency in coagulation factors as shown here on the left side. With coagulation or anticoagulation, there's a long R time. The K time is the time from the end of the R until the clot reaches 20 millimeters, and this shows the speed of clot formation. Next is the alpha angle, which is the rate of fibrin buildup and cross-linking and is affected by fibrinogen function and to a lesser degree by platelet function. And then the MA, the maximum amplitude, affected primarily by platelets and to a lesser degree by fibrinogen. A decreased MA is consistent with reduced platelet function, and then lastly is LY, which is basically a function of fibrinolysis and is prolonged in primary fibrinolysis, as shown here. Also on the left side sort of shows a teardrop shaped. Damage control resuscitation. Classically, resuscitation strategies targeted to restore the blood pressure to near normal goals with aggressive fluid resuscitation. The concern was that this leads to popping of the clot and causes ongoing and recurrent bleeding. Literature has shown a stepwise increase in the coagulopathy associated with the volume of crystalloids administered. And patients with massive blood loss or requiring massive transfusion protocol have poorer outcomes in response to classic resuscitation strategies. So this has changed, so the practice has changed more to the damage control resuscitation approach, which promotes selective use of permissive hypotension, early aggressive use of blood transfusions in a 1:1:1 ratio, and selective use of hemostatic adjuncts. The goal is to disrupt the bloody vicious cycle, restore normal physiology, increase end organ perfusion through aggressive rewarming, correction of acidosis, effective shock resuscitation, and reversal of coagulopathy, and minimize risk of multi-system organ failure. The two main components of damage control resuscitation are permissive hypotension and hemostatic resuscitation. But damage control strategies aim to reduce hemorrhage and optimize coagulation, but definite hemorrhage control cannot be forgotten and a lot of times requires surgical or IR intervention. I'll be talking a little bit more about the different components of damage control resuscitation, starting with permissive hypotension, which includes withholding or minimizing fluids as long as cerebral perfusion is evident and systolic blood pressures remains above the threshold value of 70 to 80 millimeters HT and should be maintained until bleeding is controlled. A landmark study from Bigweiler et al. Was published in the New England Journal of Medicine in 1994 and compared penetrating trauma victims randomized to traditional fluid resuscitation versus delayed resuscitation, and he was able to show that in the delayed group, a significant survival benefit and fewer complications in a shorter hospital stay. Hemostatic resuscitation promotes the early use of balanced transfusion. Early blood components restore perfusion, normal coagulation function, while minimizing crystallite use to prevent dilution and coagulation factors. The initial evidence came from the military, where in the combat settings was limited access to blood banks and separated blood components, and so what was available was fresh whole blood or walking blood banks. And studies showed that there was an improved survival when fresh whole blood was used rather than RBCs or component therapy. This has been tried to translate into the civilian world, where we do have no access to blood banks, and studies here have focused more on the effect of increasing FFP to RBC ratios, platelet to RBC ratios, in an effort to mimic composition of full whole blood for resuscitation in patients with massive transfusions. Damage control surgery is still an important part of damage control resuscitation, because the resuscitation in a patient with hemorrhagic shock is only a means to an end, and definite control of bleeding is a principal objective in any comprehensive resuscitation scheme for hemorrhagic shock. The principle for damage control surgery is to obtain rapid control of hemorrhage and contamination with early completion of the operation, with a goal to restore normal physiology as opposed to normal anatomy. There are a couple of hemostatic adjuncts that can be used in addition to blood components for damage control resuscitation. The advantage of those is that they do not require any time to thaw, they are not restricted serologically, and obviate transfusion-related complications. The most known ones are prothrombin complex concentrates, which includes mainly vitamin K-dependent factors. There's a risk of thromboembolic complications, but it's thought to be faster at correcting than FFP and vitamin K and correcting an INR. Fibrinogen concentrates are also effective and rapidly can control hemorrhage associated with coagulopathy, and in Europe has been used a lot in place of allogenic blood products as a first-line treatment for hyperfibrinogenemia. And in the US it's actually not FDA approved for that. Factor 13 and suppress physiologic concentrations has also shown to increase clot firmness, accelerate clot formation, increase stability in vitro, and may be effective in some patients undergoing damage control resuscitation. Recombinant factor 7A was initially developed and utilized for the management of hemophilia A and B, and has shown to reduce red blood cell use following administration in blunt trauma, but is not associated with improvement in mortality. And there's concern that high doses on off-label basis significantly increase the risk of thromboembolic events, especially among elderly. Currently, there is no strong evidence supporting the standard treatment for traumatic bleeding. Apologies, this is a really busy chart, just not for reading, it's just as an overview. This is basically the UHS pharmacy reference table for clotting factors, which are available and what are the FDA approved indications, and this is available on the university website for anybody who's interested. Tranexamic acid is a synthetic derivative of lysine and inhibits plasminogen activation and plasmin activities through bonding to the lysine binding site and blocking binding to fibrin. Effect occurs primarily through preventing fibrinolysis rather than promoting coagulation. In the CRASH-2 study, improved mortality from bleeding was shown, and the maximum effect was seen if it was given within the first 3 hours of injury for massive hemorrhage, and no adverse events were noticed. Also, in non-trauma studies, it has shown to decrease the need for blood transfusion by 1/3 of patients undergoing high-risk elective surgery, diminishing postpartum hemorrhage, reduces CT drainage and transfusion in cardiac surgery patients. Current recommendation is that it should be given all adult trauma patients with hemorrhagic shock unless contraindication exists. I'll be talking a little bit more about massive transfusion, which is defined as more than 10 units of RBCs in a 24-hour period. It can also be used in the non-trauma settings, and there are a significant number of medical and surgical conditions outside of trauma that can lead to massive hemorrhage, like GI bleeding, general surgery cases, or vascular case, for example, like ruptured AAA, obstetrical complications. With massive transfusion, there was no increased rate of product wastage, no increased time to return unused units found in the literature, and it expedites the delivery of component products, most likely due to the improved communication and better anticipation of product needs. And data has shown improved survival in massively bleeding patients who underwent a massive transfusion protocol. In a landmark study, Borkman et al. In the Journal of Trauma 2007 showed a lower rate of death with high FFP ratio in military patients. In the civilian setting, Cotton et al., also in the Journal of Trauma in 2009, showed that MTPs improved the survival in trauma patients and reduced the rate of organ failure and post-trauma complications when blood products were delivered early through a defined protocol. There are a couple of different ways on how to do a massive transfusion protocol. There are formula-fixed or formula-driven/fixed ratio protocols like the one that we have at the university, where preparation and delivery of a set number of products in a defined ratio is performed, versus a laboratory-driven or goal-directed protocol, which depends on laboratory values to guide selection and amount of blood products. The thought is that in those settings, that this potentially saves money and inventory by minimizing excessive ordering of blood products. A more recent approach is a hybrid approach, which includes use of a TEG to adjust blood product transfusion, blood products transfused, and then initially with a fixed ratio and then with subsequent focused intervention based on the TEG data. Nationally, the trend has moved initially from the laboratory-driven to a formula-driven massive transfusion protocol, and now more and more people adapt the hybrid-driven protocols. This is just to overview the massive transfusion protocol that we have here at the university, which is activated by usually a member of the trauma team. The blood bank prepares a cooler with 4 units of RBCs and 4 units of FFPs, and then 1 dose of platelets with other set. First cooler is sent to the emergency room. The second and third coolers, as soon as possible, they're sent to the ORs. A fourth cooler will be prepared and held in the blood bank. And then when the empty coolers were sent back to the blood bank, usually via the dumb radar, they will swap out with a full cooler. The blood bank will then continue replacing coolers as long as empty coolers return. It is stopped when the patient dies. The surgeon stops it, or coolers return with blood products. Another important part of the transfusion protocol here at the university is the inclusion of tranexamic acid. After a massive transfusion protocol has been initiated and the first round has been transfused and the patient needs continuation of the massive transfusion protocol, a 1 gram loading dose of tranexamic acid is given, which then followed by a 1 gram infusion over 8 hours. There's been a lot of talk in the literature about blood product ratio, and so far, what is the optimal ratio still remains incompletely defined. That benefits have been demonstrated from higher FFP to RBC, platelet to RBC, and fibrinogen to RBC ratios. The prompt study from Holmco and al. Published in JAMA in 2013 was a prospective study looking at this. They found that increased ratio of plasma to RBCs and plasma to RBCs, platelets to RBCs, were associated with decreased 6-hour mortality when hemorrhagic death was predominant. In the first 6 hours, patients with a ratio less than 1 to 2 were 3 to 4 times more likely to die than patients with a 1 to 1 or higher ratio. Kuchner et al. In his study published in the Annals of Surgery in 2014 showed in his prospective cohort study comparing low ratio versus high ratio groups a better repletion of factors 5, 8, and 9, and significant improvement in survival in the low ratio group. The other thing we have to talk about when we talk about massive transfusion protocols and blood transfusion ratios is survival bias. I apologize again, this is a very small chart, but I think it helps explain the different survival bias that are associated with these studies, because most of these studies are observational studies. Survival bias number 1, if you want to, we'll look at the first 2 top charts. The first chart up here shows the timing of death. The green lines show the first 3 hours after arrival to the emergency room, and as you can see, there is a high rate of mortality within the first 3 hours, and then in the next chart below it, it's shown FFP transfused and platelets transfused, and especially in this first 3 hours, there's a low ratio of FFP and platelets transfused. So if these patients and the type 1 error is seen when this data is included in the analysis, because most of these early deaths are in the low ratio group, creating a false bias to the 1 to 1 to 1 ratio. The problem is that the patient did not die because he did not get enough FFP or platelets. They did not receive enough FFP and platelets because they died. And so they basically didn't survive long enough to receive the 1-to-1-to-1 ratio. In the survival bias 2, if these patients to the left of the green line are left out, it leaves a cohort for the analysis that is less coagulopathic and is less likely to show a benefit with a 1-to-1-to-1 ratio. Survivor bias 3 can be explained with the lowest chart here on the bottom, where two different protocols are compared, a 1-to-1-to-1 protocol versus a traditional resuscitation protocol. Blue is FFP and red is platelets again. And a lot of times in the before group, many of the sickest patients were excluded because they died prior to receiving any FFP or platelets, resulting in a group with high risk of death. And also it's difficult to show that platelets or FFP are beneficial. Lastly, survivor bias number 4, or the survivor curve, which is not shown in here. Also something that was found in the PROMPT trial was that there was a spike in multisystem organ failure 3 to 30 days after admission, and almost all survivors who had a high rate of FFP and platelets transfused. And so you could conclude that multisystem organ failure is associated with FFP and platelets. This is one of the most recent studies that just has come out, and this is one of the first randomized clinical trials looking at transfusion ratios, is the Prospective Multicenter Major Trauma Transfusion Study. They tried to determine the effectiveness and safety of transfusion patients with severe trauma and major bleeding using plasma platelets and red blood cells in a 1-to-1-to-1 ratio compared to the 1-and-1-and-2 ratio. It was a randomized clinical trial including 11 level 1 trauma centers. They didn't find any significant difference at 24 or 30-day mortality, but noticed that exsanguination decreased in the 1-to-1-to-1 group, and more patients in the 1-to-1-to-1 group achieved hemostasis. There was no difference in complications noted. Outcome, in general, only 8 to 11% of all trauma admissions will require blood transfusion, and only a minority of all trauma patients will require a massive transfusion protocol, which can be increased in busy trauma centers up to 8 to 15%. As many as 24% of patients representing with shock will require a massive transfusion, and those with massive transfusion will account up to 60 to 70% of all RBCs used. Also, it's been shown in the literature that there is an increase in mortality in a linear fashion with RBCs transfused, and it can be as high as 60 to 100%. To finish off my talk, I'm just going to review real briefly transfusion reactions and complications, as this is important for our boards as well as for the app site. Non-hemolytic transfusion reactions, one of the most common one is the febrile transfusion reactions, which is due to preformed cytokines and host antibodies to dermal lymphocytes, can be prevented through use of leukocyte-reduced blood and pretreatment with Tylenol. Bacterial contamination is very rare and sort of presents with a septic picture as due to contamination of blood, and usually caused by gram-negative bacteria that can grow below 4 degrees and more often found at platelets. Basically, treatment is to discontinue the transfusion, cultures, antibiotics, and supportive management. Allergic reactions and very rarely anaphylaxis can occur. More common with FFP and platelets is either due to transfusion of antibodies from a hypersensitive donor or the transfusion of antigens to which the recipient is hypersensitive. To prevent it, you can provide antihistaminics, and then otherwise anaphylaxis needs to be treated in the usual manner with steroids and epinephrine. Respiratory complications include transfusion-associated circulatory overload, which present with pulmonary edema, dyspnea, and rales. Thought is that this is due to rapid infusion of large volumes of blood transfused, and more common in older patients with CHF. Prevent with increased transfusion time, administration of diuretics, and minimize other associated fluids. Transfusion-related acute lung injury is shown with acute hypoxia, bilateral pulmonary infiltrates, tachycardia, and hypotension. This is a non-cardiogenic pulmonary edema related to transfusion of anti-HLA antibodies that then attack leukocytes, pulmonary leukocytes and circulatory leukocytes, resulting in injury to cellular membranes, endothelial surface, and potential lung parenchyma, prevented by limiting female donors, once noted to discontinue the transfusion, to notify the transfusion services, and then basic pulmonary support, which can range from supplemental O2 to mechanical ventilation. Hemolytic reactions, symptoms can be fever, hypertension, DIC, acute renal failure in the vague patient. Other signs can be pain at the site of transfusion, flushing, back and chest pain. More difficult to notice this in the anesthetized patient, more subtle, but can be shown with diffuse bleeding, and hypotension and ARDS type picture can be fatal in up to 6% of cases, and is due to transfusion of ABO incompatible blood. Complement fixation occurs and leads to an immediate intravascular hemolysis with massive release of cytokines, capillarily, and consequent hemoglobinemia and hemoglobinuria. Basically prevention of, by transfusing appropriate matched blood. If it occurs, stop transfusion immediately, send the patient's blood sample along with the suspected unit to the blood bank, supportive care, monitor urine output and adequate hydration. Delayed hemolytic transfusion reaction can cause anemia and jaundice, as well as a positive direct Coombs test is due to extravascular hemolysis. The patient usually has low antibody titers at transfusions, but the titer then increases afterwards as a result of an amnestic response. It's important to identify it to prevent recurrence with further transfusions, and otherwise there is no specific intervention. These are my references. Don't have any kids, but these are my dogs, so I'll be happy to answer any questions.
Questions for Johanna? I've got a couple of comments, but if there's questions, I'd like to start with those.
Dan, was there any movement to use whole blood, based on what the military, or it's just that we have all the components readily available here and it's easier just to send the components in?
Yeah, none of the blood bankers are enthused about whole blood due to the fact that you really have to turn it around fast. You can't store it for very long. And they're revisiting a lot of things actually in blood banking. For example, storing platelets at room temperature. People have started to realize that when they first started blood banking, they stored platelets cold, hopefully preserving their function. Then when they transfused the platelets into patients that needed platelet transfusion, the platelet counts didn't go up, which is the endpoint that people wanted to see. So then they stored platelets at room temperature, and now when you transfuse platelets, you see the platelet counts go up. Well, people are starting to think now what that means is the cold platelets actually went to sites of hemorrhage and created hemostasis. And that's why they weren't in circulation to be measured. They were actually functional. Whereas the platelets being stored at room temperature are absolutely dysfunctional. So they just sit in circulation and do nothing but make your lab value better and reassure you that there's platelets. And so people are revisiting whether or not we should store platelets at room temperature anymore. But that's about the only, in civilian blood banking, the only change I could maybe see in the next few years in talking to the blood bank folks. A couple of things I just want to point out. The permissive hypotension work, I would caution people in the audience that was penetrating trauma in patients with short transport times. And so leaving somebody in McAllen who's a blunt trauma victim with permissive hypotension while they're transported up here for 5 to 8 hours once they get all the arrangements made is probably the wrong idea. And the blunt multiple trauma patient that shows up at our place with 2 femurs and a spleen and a head injury, leaving them with hypotension probably would cost you neurons, and that's not a trade we're going to make. So it seems reasonable in the patient that has a focal point of hemorrhage that you can go address. And so the isolated ruptured spleen, even if it's blunt trauma, I think would be reasonable to do, because you're going to get the spleen out, then resuscitate them, because you're not pouring resuscitation in and having it just spray out of the vasculature prior to getting hemostasis. But for most blood trauma, it's probably not applicable. Johanna, I think the MTP slide you used was our pediatric massive transfusion.
I had a hard time actually, and you know that's what the blood bank sent me. It used to be on the website for the university hospital, and I couldn't find it, so I contacted the blood bank, and that's what they sent me.
Okay, that's basically half the adult protocol.
Okay, yeah, I was.
And so the adult protocol is 8 and a platelet pack with every cooler, every round of coolers. And then, so that was our pediatric protocol, which is for patients under, I think it was 30 or 40.
Yeah, I don't know. It disappeared from the university website by now.
Okay,
The
so
clinical protocols. It's.
So we need to improve the website.
Yeah.
That's not your fault. That's our fault. And then, as Johanna mentioned, transfusion reaction is a fairly common boards question, both on writtens and orals. I don't remember the exact scenario, but there's a case of, I want to say, right colon cancer presents with anemia. As you're operating on them, anesthesia starts a transfusion, and then you get bleeding from everywhere and hypotension, and the urine turns dark. What do you do? Okay, so you need to be prepared to talk yourself out of that situation on your oral boards, because that's a real life scenario and it's an oral board scenario. And so as you prepare for your boards, be prepared for that. And then the last comment Johanna talked about, and I just learned this in the past month as I'm working with the blood bank on a project, but the diagnosis of trolley is probably way underdiagnosed, because the blood bankers have defined it in a way that basically minimizes your ability to blame the blood. And so it only applies if a patient has reasonably healthy lungs, then goes into bad lung failure within 6 hours of an FFP transfusion, and you can't identify any other factor that would have led to that respiratory failure. And so our trauma patients that come in with rib fractures and pulmonary contusion and are getting massively transfused, we know they have multiple risk factors for bad lung failure, and if you can't point to a single unit of FFP that you can blame and the deterioration occurs shortly thereafter, then you can't call it trolley. And so we may need to broaden the definition or just recognize it as a possibility. There's really nothing to do once it happens, except the blood bank looks back at all the donors and will bring the donors back in and rescreen them and maybe make them not eligible for donation, or at least not eligible for FFP donation. They'll take their red cells and their platelets, but they won't take their FFP. Yes, Guillermo.
Do we have, as other institution, the regulation not to give plasma from females to avoid decrease? Is the same here?
I'm a transfusion medicine fellow, yes.
Right, and so
Just for everybody, because I've been proven that really lowers the incidence.
And next year platelets will start too, because there's a lot of plasma and platelets.
Excellent, thank you.
Why is that?
Oh, because of the acute reaction, and then I think this is the only transfusion reaction that is actually the antibiotics that you're getting from the blood product. So in theory, woman was pregnant and then create antibiotics, and then you get transfused and you develop a complex and they
FFP donor compatibility, correct me if I say anything wrong, please. FFP donor compatibility is the opposite of red cells. So the AB donors are the universal donors, but they have potential antibodies in that plasma. And as a result, most places now around the country, if I understand it right, are still accepting female donors that are AB just to have some universal donor stuff on board, but they're trying to minimize the use of AB. We have gone away from it, and we're actually using A plasma as our universal donor because that's what we have the most of, and we can get enough males to do that. We don't have enough AB males. AB is a very rare blood type, and AB males are even rarer as donors, and so most places are either using AB females or getting away from AB as their universal donor.
And then just another comment. Did you cite the recent JAMA study on blood transfusion ratios?
Yeah.
Okay. So it's interesting. There's up until recently, all the data looking at transfusion ratios 1 to 1 to 1 or 1 to 1 to 2 was all either, retrospective reviews of big military data sets or prospective, there we go, prospective data looking at prospective observational studies. So this is the first one that really randomized it to sort of address some of the survival bias issues you had talked about on the previous slide. And one of the things that's interesting about this study is that, and you sort of cited there, is that their hypothesis was that 1-to-1-to-1 would improve mortality at 24 and 30 days. Those are the two main endpoints, and they showed no significant difference. And it's interesting when you read their conclusions. Their conclusions are, therefore, since 1-to-1-to-1 didn't improve survival, we recommend it as essentially as not any worse than 1-to-1-to-2. It seems what I sort of take away from this study and from the previous ones is it's probably not any specific ratio. It's not so much whether you're 1-to-1 versus 1.5-to-1 or even 1-to-2, which would make sense. It seems there's no real physiologic reason why a very specific ratio would be better than another. It seems that probably the important thing is that you start giving plasma early, and some people even speculated that the survival benefit is not even so much about giving plasma early, is that people get less crystallite by starting transfusion earlier and more aggressively, and including plasma and platelets as part of that transfusion, that patients aren't getting the 10, 15, 20 liters of crystalloid during the massive resuscitation, and that may have as much or more to do with the improvements in some of the secondary outcomes as the fact that you're really giving a both balanced or hemostatic resuscitation.
Yeah, I think probably the more interesting data that's come out of this whole literature was the first studies, the initial studies on this that showed if your INR is, say, 1.3 or 1.4 on arrival, that's not a coagulopathy that you would normally treat. But in a trauma patient who was an INR of 1 30 minutes ago, and now they're at 1.4, in an hour they're going to be 2.5, and that minor head injury is going to be expanding and that sort of thing. And so kind of taking a prophylaxis against coagulopathy approach rather than waiting for lab results to come back and direct us, hey, the INR is 2.5, let's fix it. I can tell you the days of sitting in the ICU trying to catch up with an INR or a thrombocytopenia, I haven't done that in a long time, and those were pretty miserable times. And so just avoiding that is probably worth doing. But teasing that patient out that would survive in today's transfusion practices that would not have survived 10 years ago, enough to make a statistically significant difference in a prospective randomized trial is going to be a challenge, because most of the patients that are getting these massive transfusions, their outcome is really determined by their underlying injuries. And so there's just going to be a few where the coagulopathy really maybe took a viable patient and turned them into a fatal head injury or something like that.
Dan, you mentioned about the spleen as an isolated organ. That was the one that was the most obvious, way back when, before we even realized or even wanted to talk about permissive hypotension, because the patient would be stable when they came in, but after we ran a couple of liters in and brought their pressure back up, then they were unstable. Is that what you normally do with these, if you identify the spleen as the organ of injury?
Well, actually, we still see kind of sometimes the scenario you're describing, because when you're in the resus room and all you know is you got a blood trauma patient with a low blood pressure, we still resuscitate them. And if their hypotension is, initially we start with crystalloid. And so it's rare that you have enough data to think to yourself, hey, this is a spleen, let's keep their blood pressure low while we get them to the OR. I mean, occasionally you'll be sitting in with them in CAT scan, and they'll have initially responded to the resuscitation, then they'll drop their pressure on the scanner, and you'll see the spleen on the scanner, and you'll say, hey, leave them about 80 while we go to the OR, but that's like a 5-minute process. But we don't do any prolonged permissive hypotension because you don't have the data in a way that adds up and allows you to, because a blood trauma patient with hypotension, you don't really know.
But it's a lot faster than it used to be.
Yeah, well, that's the thing.
CT scanners.
CT has gotten so fast that it's kind of changed the practice. Dr. Posada, you're going to...
Is this a very minor historical footnote? Because I want a friend of mine to get credit. When I was in medical school in Mexico, I had a classmate by the name of Francisco Javier Rodriguez Herman. His father was from Mexico, his mother was from Germany. He was incredibly bright. And halfway through medical school, he realized that the limited resources in Mexico for the research he wanted to do were not going to allow him to do it. So, using his mother's connections, he moved to Heidelberg. He finished medical school in Germany. By the time I was at the Mayo Clinic doing my residency, he was at Harvard, junior member of the faculty, and had written the seminal paper, the front lead paper on the New England Journal of Medicine that described diffuse intravascular coagulation and consumption coagulopathy. So it all started with this friend of mine who wants him to get there.
Well,
Anything else? All right, thank you.
thank you.